It's my pleasure to welcome you to this exclusive webinar, Nursing, Trauma and Mental Health in a COVID World, with Professor Nicholas Procter. By doing so, I'd like to take this opportunity to acknowledge that the University of South Australia is on the traditional country of the Kaurna people of the Adelaide Plains. We recognise and respect their cultural heritage, beliefs and relationship with the land, and acknowledge that they are of continuing importance to the Kaurna people living today. And we extend that respect to Aboriginal peoples from all areas of Australia who are present with us today. This webinar will be recorded, which just means the presenters and the presentation slides that you can see on your screen now. Thank you also to those of you that provided questions when registering. These have been collected and summarised within the presentation. You can also add questions live by using the button below, and we hope, time allowing, that we can include some of those too as we get to the end of the presentation. So without further ado, I'm delighted to introduce Professor Nicholas Procter, who is the Chair Mental Health of Nursing and leader of UniSA's Mental Health and Suicide Prevention Research Group. He is Australia's national representative to the International Association of Suicide Prevention and a member of the expert advisory group to the Prime Minister's National Suicide Prevention Advisor, National Suicide Prevention Task Force. Professor Procter, welcome, and thank you for giving us this presentation today. I'll return on screen as we get closer to the Q&A, but for now, it's an absolute pleasure to hand over to you.
Thank you very much, Imogen, and thank you very much to the alumni team and advancement services team for facilitating tonight's or this morning's webinar, depending on where you are. It's either this evening or perhaps during the day or perhaps early morning for you. So thank you very much for taking time to join us. Tonight's presentation is so topical, of course, because global pandemic of COVID-19 has impacted on the lives of people around the globe, literally around the globe, and also it's a pandemic that's at different stages of manifestation and impact. So tonight's presentation takes that into account. We will have time to consider the immediate impacts and of the nature of this pandemic, but we'll also begin to think about life after COVID-19, so mental health and wellbeing and suicide prevention during COVID-19, but also mental health and wellbeing, trauma, nursing in life after COVID-19. And like many of these types of subjects, it's always important to think about our own self-care, our own mental health and wellbeing. And so it's inevitable that we will talk about topics that can be sensitive for some people, topics that may be triggering either of a situation that you have had or lived experience or living experience of mental health challenges, or indeed triggering of a person that you have cared for. So just really a reminder that certainly those people in Australia would be aware of the many excellent support services that we have available to us, and you certainly have your EAP services. But Befrienders Worldwide would be an organisation that globally would be able to direct you to online and other forms of support. So just really an acknowledgement of that. So let's look at what we're going to talk about tonight. What we're going to talk about tonight is fundamentally the way in which the disruption and the change of COVID-19 has impacted on our lives. So to be able to tackle this disease, to tackle the pandemic, the mitigation and elimination techniques, are they themselves techniques that have meant job loss, shutdown, springing or triggering financial hardship, and certainly far-reaching mental health and trauma-related impacts. So when you work in nursing and healthcare, people from the outside world come into your world, whether it's the emergency department, whether it's the hospital inpatient setting, or indeed whether it's in primary care in other areas. So there's now never been a greater time to begin to think about mental health and suicide prevention. And one of the things that I'll be making a fairly strong point on tonight is the way in which individual and self-knowledge or team knowledge can be an extremely valuable mechanism to be able to know how and when to move in new ways. And I'm going to draw down on some things that are happening currently in South Australia, particularly a communities of practice initiative that's unfolding across the state. So we know that COVID-19 has brought tremendous fear and uncertainty and information overload. So the media has a really important part to play in COVID-19 times. We, for a while there, were really hanging on daily updates. So there's fast-moving daily updates and indeed footage of very graphic scenes of people who are being buried in mass graves in parts of the world. And we need to know what's going on because we need to be able to make meaning of all of that. But that kind of disruption can also bring experience of anxiety and fear and uncertainty. And I guess my main point here, and I'm going to come back to this, is that that's a normal reaction to an abnormal or unusual set of circumstances. So what we know about our central nervous system is that when it's overwhelmed by stress, it will set off a range of powerful thoughts and emotions. And we'll move to this place of becoming quite hypervigilant around our world and what's going on. And that's actually how we're wired up. We're wired up as humans to be vigilant and on alert. So what I also recognise about how COVID-19 triggers dangers in our lives is the way that the disease spread exploits the very things that humans do really well. So what makes COVID-19 particularly dangerous, in my view, is that it exploits what humans are wired up to do. They're wired up to interact with each other, to come close to each other, to embrace each other, to shake hands, to show outward signs of affection and interest, to work side by side in teams. Now, in physical distancing, in other mitigation strategies and important steps that government have instructed us, our chief public health officers have asked us to do or instructed us to do, it removes us from what we do naturally. It stops us in our tracks from the things that we love to do because the virus takes advantage of the very human instincts that we have in all of our social and working lives. And people working in nursing healthcare will know exactly what I'm talking about here, particularly in aged care and residential care, where loved ones have not been able to see their family members, their grandchildren. People have not been able to hold a newborn baby. People have not been able to attend the funeral ceremonies for a loved one or a family member. So what we've really got here is something that is very powerful, highly contagious, but exploitative of the things that humans love to do. And just to illustrate this in really graphic terms, I've just taken a tweet from Josh Frydenberg's Twitter feed, which really highlights the way in which he automatically went to shake the hand of the leader of the opposition in Australia, Anthony Albanese. But Albanese reminded him, no, we shouldn't do that. And if you look at the text, it's a habit that's hard to break, but important reminder of distancing. Now, they understandably use the term social distancing. I much prefer physical distancing because I don't want social life to stop because of these distancing techniques, these very important techniques that are needed. But it does go to the heart of the point that I'm making, is that we are wired up, we are naturally attuned to shaking hands and greeting in traditional ways. And we've also seen that in intensive care units, and I've certainly had conversations with intensive care unit nurses recently about the way in which they've had to endure some tremendously distressing and conflicting encounters with a loved one at a time when a family member is dying and loved ones aren't able to be present at the bedside because of the important mitigation strategies. Personal protection equipment has been tried in some cases, in some instances, but it's just impossible to have a large gathering around a person. And this is something that we're seeing in other countries, certainly across the United States, in Europe, in particular, in South America. So we have, we have a very serious, if you like, catalyst for moral distress of clinical practice, particularly for nursing and healthcare workers. So this is a very powerful thing. For others, the pandemic has been triggering for reasons that are not readily visible to us. So For some people with a past experience of war and conflict, detention, the experience of pandemic can be triggering of the brain's fear center. I'm going to come back to that in a little moment. But what we know is that when we talk about triggers of past events and experiences, we are really talking about the re-experiencing of past traumas, and that's an immediate place of re-experiencing. So there were increased heart rate, sweaty palms, a sweaty body, a sense of impending doom, a sense of fear, can be the physiological and psychological dimensions of a re-triggering of the brain's fear center. So fear and hopelessness, anger and guilt and shame, moods that can swing from being edgy and cross, irritable, to detached and numb. So if you like, there's fluctuating states where circumstances can come and go. And what I say about this, and what many experts in the area would say, is that we need to be self-aware and prepared to find these responses in ourselves and others. And it is our brain that's essentially pushing this out in our lives, and particularly a small almond-shaped organ called the amygdala that triggers these emotional responses. And I'm thankful that we have this organ. This is a very valuable and important organ. This is what keeps us alert if we're using an ATM machine in a foreign country, or if we're walking into a darkened street, or in a car park late at night. It's a threat detection center. Think of it as a threat detection center. It's something that humans really have had for since early years, early origins of human life, as something that protects us. And what we need to do is moderate that with the thinking brain, or the prefrontal cortex. So think of the amygdala as the emotional brain, part of the emotional brain, but it's really the thinking brain that we want to be able to activate. So we've got this amygdala that's a very tiny organ, the engine room of threat-related attention bias, so a very important human function. And thank goodness we all have one, because it receives incoming information. So think about pandemic and the height of pandemic, lots and lots of information, daily counts of infection, daily counts of death, fears and anxiety about social distancing or physical distancing, preferred term, whether we touch something, whether we've had good proper hand hygiene. And the fundamental purpose of that organ is to really question the environment. Is this going to be a threat to me? And for some people, it's activated, if you like, an extreme behavioural response. So a rush on supermarket shelves of toilet paper and other products. So somehow there's an on mode, a switch. The on switch is triggered that perceives threat in such a way that it is, if you like, disproportionate to the reality. So we do feel afraid, reactive, and vigilant, and I think that helps us understand the surge on particular disposable products and items in the supermarket shelf. But it is a threat detection centre that's a better safe than sorry centre. So this is why we need to work to moderate that and work through, using our more sophisticated aspects of the brain, whether or not a threat is real or imagined, likely or unlikely. So the big takeaway here about the amygdala and central nervous system is, in a COVID-19 world, and indeed in a post-COVID-19 world, this is why trustworthy, reliable information from one or two reliable, trustworthy sources is so important. But importantly too, reciprocal human connections can be quite soothing. So reciprocal human connections, the things that we love to have with people who are close to us, are actually calming of our brain, and they activate that thinking brain, if you like. And a little bit more biology, I'm not going to overwhelm you with this, but it's a very important platform for what I'm talking about, is when this region of our brain, this frontal region of our brain is strong, we're able to manage difficult thoughts and emotions without being totally overwhelmed by them. So the ACC in particular, so the anterior cingulate cortex, the frontal part of the brain, the thinking brain, regulating emotion. This is the part of the brain, if you like, and this might be very relatable for some people. if you want to fire off an angry email about something or make a communication about something, this is the part of the brain that says, oh, no, Nicholas, that's not a good idea. Don't do that. Push the pause button. That's what this part of the brain does. It's a part of the brain that we want to have more activation of in COVID-19 times. So a little story. I came across a midwife. I watched this unfold. This is a midwife in practice, wanting to make a very angry phone call, wanting to give a blast to the pay office at work because she didn't get paid for an extra shift and she didn't have sick leave documented on her pay slip. So she was absolutely fired up, ready to go, very triggered, ready to go. Now, people around her recognised this and they used techniques, grounding techniques and deep breathing techniques, trying to have her come around to the idea that this is not a good idea, helping her manage those emotions. Now, let's just work through this calmly. Maybe you might do something that later you might regret. Now, when it was calmer, when the situation was calmer, two things came out. One, this midwife had never worked an extra shift. And two, the night before this telephone call, the night before the call that she wanted to make, she saw news on social media. She had a social media device in bed. And she saw news in social media of a midwife that had died in the United Kingdom from COVID-19 of a similar age. And that was a highly distressing situation for her to witness. So this small example or exemplar really serves to illustrate the way in which we can have runaway emotions in a runaway world. And we really need to think carefully about that and use techniques to ground us and to calm us and to soothe us and to distract us so that we don't do something we might later regret. So what is this telling us? It's telling us that there is fear and uncertainty with far-reaching implications around the world. This is a crisis that's changed the way we see ourselves. It's impacted on our central nervous system. There's certainly a greater emphasis on online and virtual forms of connection, engagement, and health support. But it's also the mitigation of techniques or strategies to deal with the virus, to shut down the virus, that brought financial distress and hardship to a lot of people. And particularly people who previously thought that they could provide for themselves and their family, get through life's ups and downs, get through life's challenges, are now seeking support from mental health counselling, mental health services, and indeed online, other forms of support, financial support, housing support, a range of things. But it's also a time that there are genuine fears for the next generation of Year 12 students and certainly the next generation of university graduates who will be leaving school and graduating directly into recession. And we know from previous pandemics that entering the job market now will almost certainly adversely impact upon immediate and future job prospects. So we have these things in the wider world that are incredibly relevant and important. And there are feeling states that go with this for a lot of people, and particularly job loss and loss of status, financial stress and debt, shame, humiliation and guilt can be overwhelming and insurmountable and deepening for some people. There can be feelings of defeat, feelings that enough is enough, an unendurable situation will never get better. We have seen a surge in telephone contact to organisations such as Lifeline, Beyond Blue, the chat line and the helplines. And some of the themes that have been reported from those areas are loneliness, feelings of isolation. And what I've called here is a lack of reciprocal relationships, a lack of human connection. We're hearing reports of alcohol and substance use. Domestic violence is a very interesting one, and the New South Wales government, in fact, released a report today to say that when we compare April 2020 with April 2019, there's no real noticeable increase in domestic violence call-outs. So there's some concern about whether, anecdotally, there's an onset or worsening of domestic violence situations, but people are not reaching out to helplines, and we will never really know that. So this is a very important and a very incredibly challenging area, particularly for people who have, in these very difficult circumstances, a worsening sense of feeling boxed in by their circumstances or entrapment, which is a very dangerous place to be and has significant mental health consequences. And then, of course, we're hearing reports of interpersonal conflict And it may not be people that are necessarily in the home environment. It may be people by remote settings or in the work setting. And people who've previously been seeking and receiving mental health support are somewhat embarrassed and feel stigmatised about having to go back to that. And certainly, as I've touched on, the events can be re-triggering of previous trauma. But we're also hearing some modelling around the world of concern around exacerbation of known risk factors for suicide and self-harm, sense of loneliness, hopelessness, unresolved anger and stigma, and a range of other things. And I'm going to be very cautious around this because modelling is simply that, it's modelling. We know enough about previous pandemics, however, to know that we should be concerned. So what I say about this is that we do have a lack of robust evidence about the impact of the pandemic. It is emerging, but if we look at previous pandemics, and certainly death by suicide increased in the United States in the previous large pandemic, but we also know in the previous pandemic in Asia in particular, we did see an increase in suicide-related distress, social disengagement. And these are what we call precipitants of suicide-related behaviour. And that's a really important area. So when we begin to think about that, and we begin to think about what we would do as nurses, as system leaders, as system drivers, we start to think about kind of three main areas of suicide-related response. And I'm just going to briefly summarise some of these key areas because they are essentially quite critical. So universal, selective and indicated are the three areas. So universal, what I'm talking about are strategies or initiatives to address the entire population. So if you think about what we've seen in Australia right now, we've seen a greater emphasis on making sure that there's positive messaging about the availability of help. We're seeing that in social media, we're seeing that in newspaper and also electronic media formats. And essentially what we're trying to do is influence everybody in the community across the lifespan as far as we can in favourable ways to favourably reduce risk of suicide, removing barriers to care. And so this is a universal approach, if you like, so suicide awareness programs. I see the federal government announced just yesterday mental health first aid training for medical students across Australia, a big investment to be able to fund that. So that's a very good example of that. And certainly the relaxing of Medicare arrangements in Australia is another very good example of that. And then there's selective interventions, primarily to focus the at-risk groups in society. So we know that more men than women die by suicide. We know that people in the younger age group and the very elderly are at greater risk of dying by suicide or certainly experiencing suicide-related distress. So what we're trying to do is target frontline workers, what we call gatekeepers, who have the gateway, literally, to be able to facilitate support for people. So selective is really targeting a particular group of people, and men is one of those particular areas. So what we've seen in recent times is the Are You OK Foundation refresh the mateship manual. This is a really good example of selective indicator or selective intervention for suicide. And the University of South Australia, our team at UniSA, partnered with the Are You OK Foundation to relaunch this mateship manual, and I'm very pleased that the details will be sent to you. I'm very, very pleased with how that's come out. So what we're really interested in here is people who've had a trauma exposure, and we're particularly concerned with men who may feel that I'm all right, they're stoic and they can sort of shrug things off. And what we really want to do is target them and ask questions about, are you okay? And also give guidance to people who do ask that question and they get a pushback. No, I'm all right, mate. Don't worry about me. Well, what we're talking about in this manual is techniques to be able to come back and really check in with people to see if something is needed, and techniques around follow-up. So that's important. And indicated strategies are very specific for high-risk individuals. So in nursing and healthcare, you will see people in the emergency department, intensive care units, community clinics, community settings, who have attempted suicide, who present with suicidal ideation. And what we know is that particularly safety planning is an effective means of reducing suicide. So this is a very specific indicated intervention for people. And one of the greatest things that we have seen in recent times, particularly with safety planning as an indicated intervention, is that it's co-designed. So if somebody is presenting with suicidal ideation at risk of suicide, they're coming together and joining with somebody, working on things that are right for them is fundamentally important. So this is one-to-one support and treatment. And we're seeing around the world an increase in the role of nursing and healthcare workers, allied health workers, involved in the co-development and co-design of safety planning. So what do I mean? It's the co-development of personalised strategies to be able to get through things that are very difficult, to be able to manage suicidal urges. So we don't want people to white knuckle it. We don't want people to do a white knuckle ride. We want people to feel supported, and we want people to have something to alleviate their situation, their feelings and their thoughts at the onset of worsening of suicidal urges. So in safety planning, what we're saying now is that we identify reasons for living, we recognise distress triggers, we think about those internal coping strategies. So if you think about what we've been talking about with COVID-19 and the triggering nature of that, the distress triggers and the outcomes of unemployment, fear, financial hardship, entrapment, a range of other things, the precipitants of suicide, we could begin to think about how we might be able to work with people who are at risk of suicide and being able to support them by identifying their reasons for living, recognising particular distress triggers, employing internal coping strategies. And you'll find that incrementally as we make our way along the page here, we can actually ensure that we are personalising this for the person right up to emergency care and emergency support. And you'll see on item 7 there, it's about reducing access to lethal means. And there are many very, very good examples of safety planning. And it's important because suicidality fluctuates over time. It's really hard to think straight in a crisis. And this can be a time when people are in crisis. So if you can't think straight in a crisis and you're learning how to do that, you're learning how to get through a crisis, you're practicing specific template of thought and behaviour. And when you practice a particular template of thought and behaviour, it's easier to put that in place over time. So most people who experience suicidal urges will get through them. So collaborative, co-design, thinking about ways to have competence and accomplishment to be able to cope through these very difficult times. So if we flash forward now and think about people who are losing their jobs, getting knocked back, not getting an answer from a job application could be very triggering for some people. And that triggering can be, I'm worthless, I'm useless, I'm no good. And so this is about enhancing strategies to be able to mitigate the onset and worsening of those distressing thoughts. That's exactly how safety planning can work. So people who've got a past history of suicidal behaviour or suicide attempts, people who've made previous preparations for suicide, and a history of the onset or worsening of thoughts of suicide. These are the ways in which safety planning has been demonstrated to be very effective. And most of this we've discovered through people who have had trauma, and that group in particular is a group of veterans. So much of what we've learned about effectively helping people through difficult and traumatic times kind of comes from our deep understanding of the lives and crises of veterans. And so this is kind of like the origins when there's been more work done in recent times with, understanding the way in which it reduces hospital contacts. So if you're a nurse working in the ED department, safety plannings are recommended tools to mitigate suicide risk for people who come to the emergency department. They can be also used in outpatient mental health clinics. So the science is in and the science is good. The science tells us that you can actually have a reduction in the number of missed appointments to outpatient. You can have a reduction in the number of people who identify as crises and being in crises and suicide-related distress. And you can see an increase in the use of helplines and other forms of support. So again, mitigating crises and, if you like, preventing the trajectory to suicide. But what you need to do is be a good listener. And at the heart of nursing and healthcare is listening. being a good listener. And I say listen to listen. Don't listen to respond. Listen to listen. Do capsule summaries of the things that you hear about, the motivations for suicide-related distress. Empathise and validate the person's feeling, and validate the valid. So validation is incredibly important. Assume the person is an expert on their thinking. They're an expert on the topic of their experience and an expert on their thinking as well. Another area that we're seeing nurses become very active in is in the development of communities of practice initiatives. And what we're seeing, given the heightened level of anxiety and social isolation, the unemployment crisis, the idea of coming together in a considered and thoughtful way to help prevent the COVID-19 crisis becoming a worsening situation for people across the lifespan is an incredibly useful way. We're hearing stories like we're all in this together. And I think what this does, communities of practice, is it brings people who don't normally work together every day, but they come together because they find value and meaning in their interactions. They truly believe in the value of spending time together. They see some important way of discussing, common areas of concern, trying to problem solve certain areas. So we have communities of practice amongst nursing and allied health workers right now in South Australia, and indeed they're being discussed in other states, other parts of Australia. And this is an example. It might be a little bit hard to read, but this is an example of an invitation that was recently sent out for a communities of practice event in South Australia for people who work in child adolescent mental health services, so for community teams. So our team at UniSA has been engaged by the Office of the Chief Psychiatrist in South Australia to facilitate these coming together communities of practice, given all of the heightened anxiety and concern, financial crisis, to be able to have a considered nursing response, a considered mental health response, a considered healthcare system response for people who are impacted directly or indirectly by COVID-19 and all of its effects. So we have groups of 25, I think is the last count from yesterday, group of around 25 people who are participating in communities of practice initiatives. So this is a really important initiative and something we're very, very pleased to do. So they involve people who don't necessarily work alongside each other, but if you think about your own workplace, if you think about the way in which you relate to each other, and you might have some casual conversations in the tea room or in other settings in the workplace, this is a bit more structured. It can be a loose arrangement, but you fundamentally do it because there's value and meaning. And what I say in communities of practice, which is absolutely essential, is that it must be a safe place for staff to connect and know how and when to consider new ways of working, have debate, discuss ideas with a shared purpose of advancing fresh thinking. So if we think about fresh thinking in a COVID-19 world or fresh thinking in a post-COVID-19 world, we're really thinking about fresh possibilities and how we might know what is an effective way to do an assessment over the telephone, or maybe to engage someone by telephone, by remote means, by virtual means, who's perhaps reluctant to engage by those means. And physical distancing or other protocols are in place that prevent the worker from being able to visit and do home nursing or community nursing. So this is the kind of place that you can begin to think about those strategies. And healthy communities are the ones that have some of the most robust debate and analysis and thinking as a way forward to be able to manage these sorts of possibilities. Some of the benefits around communities of practice are information exchange and capacity building and team building. So what we've seen in South Australia is that as we've brought people together through the Zoom platform, everybody kind of comes together and they're beginning to share resources, they're beginning to discuss those new techniques. One of the interesting things we've done in South Australia is we've brought government and non-government sectors together. And many of you will be aware that one of the greatest challenges, or two of the greatest challenges in healthcare, is continuity of care and the prevention of silos of care. So continuity of care is about information exchange, sharing and knowing information about a particular case or circumstance, the test that's been resolved, but it's also about relational continuity. And supporting people in COVID-19 times is a highly relational act. And so there's a very real possibility here of co-design of different resources and different supports. And where I think we're going to see through this post-COVID-19 period, or as the pandemic plays out and, you know, across Australia and other parts, the co-design of resources and guides, frameworks, if you like, to be able to address any unmet needs. So safety planning is a very good example of that. Doing safety plans over the telephone would be a very good example of that. Here's a tweet that I'm sharing around some of the big messages. Now, Alice Cole-King is someone that's really worth checking out, and she's a psychiatrist in Wales who's the leader of the Connecting with People approach. And Connecting with People is a suicide prevention, mental health promotion framework that is embedded in the state plans of South Australia, Tasmania, New South Wales, the ACT, and I think other states are soon to join. And I think we may even see the Connecting with People approach in other forms of government, other levels of government, like local government and federal government. So what Alice has done in this tweet is kind of captured some key messages of my talk tonight. It is a challenging time. It's triggering us. It's triggering our central nervous system. Be kind to each other. Be kind to yourself. Recognise the fears and the angst and the challenges, if you like, connected to the neurobiology of who we are as humans. But by building a wellbeing plan, by being kind to ourselves, by being patient, by using techniques such as what we used with the young midwife, can really enhance wellbeing. There's a website there, learn.formentalhealth.com. So if you have a pen and paper, learn.formentalhealth.com is a place to go where you'll see a bit more about safety planning. And she talks about it as the mental health equivalent of a car seatbelt. So the mental health equivalent of a car seatbelt, putting on a seatbelt, you never know when you need it. It's a good thing to have. And there's also another website for more detailed information and some short videos, stayingsafe.net, stayingsafe.net. So go to both those places and check out those things. If you're a Twitter person, you could also follow Alice on Twitter. She's very active on Twitter. Be kind to yourself. Don't bottle things up. So that's about self-care and the compassion that we might give. What I'm saying here is the compassion that we might give to people that we care for as nurses and healthcare workers is exactly the sort of compassion that we need to give to ourselves. And we need to be kind to ourselves and to other people. And perhaps maybe be a little bit more patient with people. So some great, really, really great messages there that I think tell a powerful story in their own right. So tonight's presentation, we've covered some material that, you know, can be distressing, and I'm certainly aware of that. And please, just a reminder of these services, and certainly these are national services, befrienders in the United Kingdom and elsewhere, but also those resources, and I'll just go back, these resources here also have supports and guidance for people. If you need to get help right now, that's also a great place to go. So thank you very much, everyone. That's really going to draw my talk to a close, and there are some references here if you're interested. I've highlighted the Stanley and Brown, Greg Brown and Barbara Stanley are really are the pioneers on safety planning. So you'll see quite a lot of information from Greg and Barbara in particular. I'm very conscious that we may have some questions to consider at the end of this presentation, and I know some questions have been presented in advance, and it might be useful now to perhaps consider some of those questions. And I know Imogen is just coming back online now, so thank you.
Thank you, Nicholas. Thank you so much for the very thoughtful presentation. And for me, I I really liked how you made that distinction between us remembering that it's physical distancing and not always to just coin the phrase that it's social distancing, which I think is a really important distinction to make. You're quite right, we have some Q&A and we've put those on the slide for you to talk us through. We've got 10 questions that covered the majority of questions that came through as people registered. If anyone else wants to add a question, they can do so as well by using the button below, so I'll keep an eye on that for you. But if it's okay with you, if you could take us through some of your thoughts to some of the questions that have already come in.
Look, I think the supporting of mental health is fantastic. So if we even consider some of the opening questions here, and, you know, finding within yourself the compassion, I call it self-compassion. So the compassion that you might do in nursing and healthcare or midwifery care or allied healthcare, just turn that around and put that onto yourself. So it's okay if you don't feel like going out and doing stuff and being social sometimes, that's okay. If you would rather go to the gym or go for a walk than perhaps doing something else and you're not keeping up with something else, that's okay. What we know is that if you can go easy with yourself and go easy on some of the things that you might impose to be pressuring you to perform or do certain things, try to go easy on yourself as much as possible. Have time for sleep. Don't take devices to bed. Some people who are in nursing and healthcare are telling me that they've got a routine around this now. They'll listen to some nice relaxing music, 35, 45 minutes before they go to bed, no devices, and slowly shrink away. No bright lights, soft lighting, no alcohol in the evening, moderate all of those sorts of things. So certainly the things that we can do to look after our physical and mental health and well-being are extremely important. If you're worried about a loved one, if you're worried about the mental health of a loved one, if you're worried about your own mental health of a loved as well, talk to someone that you trust. In the Medicare arrangements that we have in Australia right now, there's never been an easier time to get help and to get counselling. And what COVID-19 has done to us as a nation has been difficult and challenging. We've lost over 100 people, 100 lives have been lost in Australia and over 100,000 in the United States. But we've also seen the coming together of the best thinking and action to be able to support people who are doing it tough. So be kind to yourself. It is true, if we look at another question there, it is true that some people who've had trauma exposures either as a worker in intensive care or as a patient, if you like, in intensive care, will have some longer term anxiety, depression, stress-related response symptoms. So about 10 days ago, we saw a publication in the Lancet that was a systematic review, which is a very high-level review of over 70 studies about the mental health or psychiatric implications of COVID-19. The big takeaways from that systematic review are, as I've just said, some people will have some residual, few in number, but residual mental health problems, difficulties, stress-related, depression, anxiety, post-trauma stress-related. Most people, those experiences will be transient. They'll be short-term. And we don't know a lot about the most effective way to mitigate and favourably shift risk of something more enduring taking place for people. But we do know a lot about lifestyle and health factors to be able to make a difference.
And one of those questions then, Nicholas, is also about the silent things to look out for in people's behaviour. Is there anything that we should all be keeping an eye on in particular?
Yeah, look, there is. And the Are You OK brochure, the Are You OK mateship manual captures this really well. And I'm not going to use any technical language here. Someone's just not the same. They're not their usual self. And that's a key thing to look out for. And maybe that not being their usual self is maybe they're more moody, more irritable, more distant, more preoccupied, less engaged, less wanting of doing things. Now, some of that is kind of part of the context in the world that we're in. We're being told globally to stay at home, stop the spread, only go out if you have to, stay at home and go to work if you need to. And that's about the only travel you do or essential items for shopping. But there's something profoundly different for some people where there not being the same has the characteristics that I've just described. Not sleeping, maybe more alcohol intake, maybe more irritable and possibly more aggressive. They're the sorts of things that you would need to be concerned about, and asking, are you okay? But also going back, if you get some pushback, are important techniques to follow.
And on that point, I'd like to just jump to one of the live questions we've had through, because I think it might bear on that too, is what role do you think art therapy could have in managing stress and anxiety and well-being?
I think it has a great role, and one of the things that I know can be very important in art therapy is meaning making, and finding the shapes and the colours and the symbols and the positioning of shape, colour and symbol, the size of shape, colour and symbol for meaning making. People working through what's happened, people working through flash forwards about what they think could happen. And there are certainly studies, there are published scientific studies of changes in neuroimaging because of art therapeutic techniques over a sustained period. So I think there's a place for art therapy, there's a place for drumming, there's a place for music therapy, and these alternate enlargement, if you like, of alternative or non-traditional, non-medical traditional therapies are incredibly important and very safe to do.
And I can't help but notice that you also have pumpkins behind you, so perhaps also for nature as well.
I couldn't agree more, and thank you for that. This is one of my favourite images. It was given to me by one of my team, so thank you, Heather, for that. What a lovely collection of pumpkins, somewhere in regional New South Wales, I'm told. And I look at those pumpkins and I think, oh, look at all that soup. Think about all that soup that's just waiting for somebody. So, but it's a lovely image, and green is a very calming colour as well.
Another one of the questions that we have, which is on the slide, is about as we kind of return to normal, and I use that phrase carefully as well, because I know in terms of assisting with mental health and those changes, is there anything that you could add to that?
Look, I think one of the things that is so true in returning to normal is don't rush to that. So let's do things slowly and incrementally. And what I say too is talk about that as a family, as a team, as a husband and wife, as a son and brother and sister, whatever it may be. You know, talk about things and plan things. So we think about what's happening. We've got sporting calendars starting up. We've got more people on public transport. We've got a range of things coming out now. So plan things, plan your day, have a plan for returning to normal. So pack the night before, don't feel rushed. If you've been home working particularly, think about maybe, are there going to be cafes and restaurants near where I work? Are they going to be open? Can I go to my usual place for a meal? So plan ahead, think ahead, anticipate that. Think about maybe if you're concerned about the crowded public transport to be able to travel to and from work, plan that and maybe leave earlier or perhaps leave later if you can do that. If you're an employer, talk to your staff about that. Have that conversation about the things that you would like to do and come to a shared understanding. Go gently, go slowly. COVID-19 has been a lot of fast time. We've had a lot of fast time, fast moving. Now we need a little bit of slow time. And that's slow time to reconnect with school, university, studies, work, sport, and so forth.
Thank you. And that brings on to another question when we start to think about some of the effects that we've had on the economic outlook. And I know this is something that you also wanted to make note of at the end of the presentation. What preparations can be undertaken by mental health practitioners in particular?
The preparation is really about how can I know how and when to move in new ways. In a traditional way, I would do a home visit, or I would expect people to come into the clinic, and the waiting room scenario would be ideal. There's no physical distancing required. What do I need to do? How can I know how and when to move in new ways so that my craft as a practitioner, as a health worker, I can still be true to that craft, still be socially and physically responsible in that craft, maintain a connection, maintain a therapeutic relationship with people, and know that within myself, if I'm struggling with something, how I I'm consciously aware of that. So many health workers have been impacted by COVID-19, and that's not visible to the patient population. And what I'm talking about is their husbands or their children have lost their jobs and they're in the household. So there's stress in that household, and maybe that healthcare worker is the only person receiving an income in the house. So go gently, go thoughtfully, talk to others in the process, be patient with others in the process, and be patient with yourself in the process as well.
And one of the other questions we have on the screen as well, Nicholas, is about what changes we might see within the education sector. But I suppose it's not just within the education sector if you're studying now, but in terms of lifelong learning for people in the profession. Are there any changes that you're anticipating?
I think we're going to see, and I'm very pleased about this, I think we're going to see a greater uptake generally in society of expert medical advice and public health. And I think there's been a revitalisation of public health advice and science worldwide, and certainly I've noticed that in Australia. So I think that's good, and I think that's going to draw a lot of people into the professions, certainly nursing and healthcare. The training of nursing and healthcare and higher education sector has public health knowledges. I think we're going to see curriculums change in nursing and healthcare so that we take more careful interest in the impacts of pandemics and potential pandemics. I think we're going to see better practices in infection control. So people working in nursing and healthcare and the education around infection control. And I think we're all talking about mental health. We're talking about it tonight. Suicide prevention and mental health are certainly going to be much more thought about. It's definitely in the Australian context, it's a national priority area. Prime Minister has elevated it as a national area. So I think taken in combination with each other, we're going to be more careful and conscious of all of these things and the way in which they interact for us as individuals, but also as a society.
And to that point about some of the changes that we might see, someone also has added to the question that we had before about art therapy. Is there a way that we can facilitate this more in the medical sector?
That's a great question. And I have seen some good examples where people are willing to be more innovative and more nimble, more open to possibilities, particularly if the understandings are really clear and built around maybe the importance of therapeutic engagement, early intervention and support, sense of belonging. And, art therapy is probably one of those things that you can do through virtual means. I imagine that there are no delivery platforms that would enable art making for people, therapeutic use of art making in virtual means. So this could be something that could be potentially very good for people who are isolated and people who are unsure. So yes, I am seeing people are relaxing a little bit and opening up fresh possibilities. So that is encouraging, at least.
Yeah, and the conversation is great to see as well, and to take those opportunities.
Yeah.
Someone has made a comment, how can we ask our loved ones to support us during particularly mentally difficult times?
I think to ask the question in quiet moments, not when there are difficult moments. So one of the things that we know so well in mental health practice is that when things are going well, it's easier to have conversations about times that are not going well. And that's about pre-planning. That's, if you like, that's at the heart of safety planning as well. So when you go to stayingsafe.net, you'll see this explained in more detail. And the question is, if you're sitting with a loved one, the question is, when it comes to those feeling states, when you're not feeling okay, what's the ideal scenario for you? What do you need from me? What do you want to hear from me? What don't you need from me? What's the right thing for us to do together as a family if we're out somewhere? Now, these don't need to be heavy conversations. They don't need to be conversations that are back to back. These could be conversations that happen incrementally and processually. They could happen at different times. And then start to write a few things down about what you arrive at, where you land with some of those answers. Now, people who are in mental distress say that when these techniques are used, they can be extremely helpful. So it's pre-planning. It's a bit like having a plan for when you return to work and return to football or sport or something like that.
Yeah. And we've had a comment as well, just saying, excellent presentation, Nicholas, and agreeing with your response about arts in mental health, and making the comment that one of the challenges might be to do around grant funding and how we can lobby for that.
Yes, yes, I agree wholeheartedly. I agree. Yeah. Good.
And I think we've covered the majority of our questions, so I don't know if there was, and we're coming up, well, perfectly within time.
Right.
If there were any final comments that you wanted to make before?
Yeah, look, I will make a final comment. I really want to thank you, and I thank the alumni team for all the excellent support and background work. A fantastic team to work with. Always have been a fantastic team. And I'd also like to thank everybody who's come online tonight and thank them for their time and their patience. Everything we make, everything we create, we share. So if you're a Twitter person, Melissa Gibson in our unit manages our Twitter account, and we share everything. So please follow us. You won't get any photographs of lasagna. You might get a photograph of a pumpkin, but not of lasagna. But we'll share resources, films, podcasts, a whole range of things. So please keep in touch and, connect with us. Be together with us. Thank you.
Thank you so much. And it's been a pleasure working with you also. And just for everyone that's joined us, we will also be sending an email out, and that will have a link with the presentation too. So people will be able to access that again. And all that remains for me to say is thank you again for such a thoughtful presentation at this time. And to say from the University of South Australia in Adelaide, a very good evening, and to take care.
Thank you very much. Thank you, everyone. Thank you. Bye-bye.